So today, we are hearing from Elizabeth Salisbury-Afshar. Dr. Afshar, let me read her bio to you. Dr. Salisbury-Afshar is a physician certified in family medicine, addiction medicine, and preventive medicine, public health, with a passion for social justice and advocacy work. Expert in the opioid-related epidemiology, policy, public health intervention, and treatment. Her main focus is supporting data-driven decisions and disseminating evidence-based practice. Past roles include serving as Medical Director of Behavioral Health Systems, Baltimore, and Medical Director of Behavioral Health at the Chicago Department of Public Health. She continues to see patients on a part-time basis and provide primary care and addiction treatment services at Heartland Alliance Health, a health care for the homeless provider. She recently started a new position as Director of the Center for Multi-System Solutions to the Opioid Epidemic at the American Institute for Research. I also wanted to add that I used to work with Dr. Salisbury. If you don't know, a family physician over at Illinois Masonic, and about 10 years ago, you have to remind me, she was one of our residents and has now gone on to bigger and better things. And in keeping with our branding of programs, our program addressed a wide variety of topics, including current events, philosophy, arts, and sciences, just to name a few. Today's presentation and our ongoing program is related to health and current events. So please help me welcome Dr. Salisbury-Afshar.
Okay, thanks so much. So I'm going to try to talk about three things today. First is just broadly, what is addiction? And as I was sitting next to Candace and we were talking a little bit, she asked me, am I going to ask people to raise their hands if they've been impacted by the opioid crisis? And I said, you know, I often don't start that way, largely because there's so much stigma around either being personally impacted or knowing people impacted. And we'll talk a little bit, and hopefully in the Q&A also talk a bit more about some of the stigma and how really stigma has perpetuated this problem and continues to be part of what we have to deal with to be able to get out in front of the opioid epidemic. I'll also talk a little bit about what we're seeing in terms of numbers, in terms of the number of people being impacted and also dying of opioid-related causes. And I'll talk a little bit about what we're seeing nationally and then very specifically what we're seeing in Chicago. And finally, I'll talk a little bit about the interventions and what we know and have seen to be working and what we're still sort of studying. So first, what is addiction? So I think, you know, I came up I was born in 1980. I came up through DARE. And I think a lot of us have been trained that this idea that drugs are sort of evil, and if we experience drugs, then it is inevitable that we will become addicted. That's essentially what I was taught in DARE. And I think what I've come to learn through science and research and understanding and working with patients is that addiction is not simply about the use of drugs. We know now through science that a lot of people have exposure to drugs and alcohol, but not all people develop addiction. And this is sort of a hard thing to wrap our minds around, especially in a culture where we have a war on drugs, right? Like drugs are the enemy and we are going to fight them, and anyone who engages in drug use is also the enemy and we are going to fight them too. And really a lot of this has perpetuated some of the problems, in my view, of where we are right now. So what we know is that we think about 10 to 20% of people who are exposed to drugs go on to develop addiction. We also know that the majority of people who have addiction, this could be to alcohol or drugs, get better without formal treatment. And so as a treatment provider, I sometimes forget that there's this whole other segment of the population struggling with addiction that I never see in a formal treatment setting. And I'll talk a little bit about treatment later, but really our goal when we think about working with people who use drugs is that we want to identify people with problematic drug use earlier. We want to offer them services earlier. We want to shorten the amount of time it takes for them to get better. And we want to reduce any negative impacts related to drug use. So this could be impact on family, impact on work, or health impact, you know, so reducing risk of HIV or hepatitis, or very importantly, death. And so other things that we've come to understand is that about 50% we think of addiction, the likelihood that someone develops addiction is genetic. We also know that environment and behavior play a large role, right? So if you're never exposed to drugs you can't become addicted to drugs, but your exposure to drugs has a lot to do with your environment. You know, where do you have access to them, but also do you see those around you using drugs, as well as our behaviors. Again, so if you never experience it, you can't become addicted. So it's this sort of complex setup for genetic links, environmental exposures, as well as your individual behaviors that go on to determine whether or not someone develops addiction. We also know that people who have experienced what's called adverse childhood events, sometimes we shorten that to ACEs, have a much higher risk of developing addiction. People who have experienced adverse childhood events actually have a lot of negative health impacts, whether that be heart disease, likelihood of developing diabetes or depression, and this holds true for addiction as well. Adverse childhood events include things like physical, emotional, sexual abuse, but they also include things like losing someone close to you. It also includes things like separation of parents. And what we know is that the more of these events someone experiences at a young age, the more negative health impacts they are likely to experience. Doesn't mean for sure everyone that has ACEs will go on and develop these negative health consequences, but we know it increases risk. And finally, we know that people who are exposed to drugs and alcohol at younger ages, we think that it really impacts their brain development, and they have an increased risk of developing addiction as they age. So, what happens to the brain as someone is developing opioid addiction? So there's something in all of our brains called dopamine. Dopamine is really critical for daily living. Dopamine is critical to our existence because it's responsible for motivating us to do things that we need to do to stay alive. It's responsible for telling us when we are hungry and need to eat. It's responsible for motivating us to continue to drink so we don't die of thirst. It's responsible for telling us that we need to procreate, for making sex enjoyable, which is obviously very important for the human race to continue, right? It's also really important for bonding. We know that mothers who, I had a really, really tough baby, but I still loved her, which, you know, if you look at like raising a brand new baby who cries literally all the time and like doesn't give you much back, doesn't even smile at you those first months, but somehow we still love them, it's dopamine. Dopamine is the thing that tells us that this is good, this is positive, and we need to do more of it. So what happens with many drugs that are addictive is that they increase the dopamine levels in the brain really significantly. And so what it tells our brain is that this is good and you need more of it. Now, interestingly, you know, working with patients, not everyone experiences this in the same way, but by and large, what we know is that most drugs that can be addictive increases dopamine levels in a variety of different ways. So, sorry, I'm going to stay here for just a minute. So, what we know is that a normal day, so like this morning I would say for me was a pretty normal day. I woke up, I felt okay. A normal day, dopamine levels in the brain is around 50 nanograms per deciliter. So just keep that number in mind, 50. If you imagine the worst day you've ever had, like the worst day, you don't want to get out of bed, you can't get out of bed, like you have zero motivation to anything for whatever reason, not necessarily physical illness, but for whatever reason you just emotionally feel like you cannot do it. We know that that number is typically around 40, worst day ever. Then you think about really, really positive things. So this could be you're eating your favorite food. This could be an intimate relationship, an intimate encounter with someone that you love. We know that that number goes up to about 90. Then you think about your absolute best day ever. So for me, you know, it could be that my kids both sleep all night long. I wake up, I win the lottery. I find out I just got a huge grant at work. Like whatever your best day ever could possibly be, that number only goes up to about 100. So our brains are meant to live sort of between 40, which is the absolute worst you can ever imagine. The day you call in and say, I'm sick, even though you're really not physically sick, up to 100, which is your best possible day ever. So what we know of substances that have addictive potential is that they increase that number significantly. And so the ranges change a little bit by drug, but for opioids specifically, they go up to as high as about 200. So over double what you can think of as your best day ever, like the absolute winning the lottery, like everything goes on perfectly. And so that's about 3 to 4 times the normal range where you are on your normal day. And so what starts to happen is your brain is like, yes, this is amazing. This is better than food. This is better than intimacy. This is better than all these other things. This is what you need to do. And so the first times that people are using opioids, they sort of go from their normal range up to this really good range, right? And this happens multiple times. And over time, the brain starts to say, whoa, wait. We are not supposed to be living at 200. We are not supposed to be living in this high range of dopamine. So over time, your brain's natural levels start to come down. And so then over time, what happens is that when you're not using opioids, your dopamine level is way below normal, and even below that 40, below that worst day you've ever imagined. Your level of motivation to do anything other than get more opioids is almost gone. And again, different people experience this differently, but by and large, this is sort of the broader experience. So then when people have opioids in their system, they're really just getting back up to normal. And so this is chronic opioid use. This isn't, I've used opioids 3 or 4 times. This is, often weeks, months, even years. And so then rather than being in this constant spiral of feeling normal to feeling really, really good, people are in this constant spiral of feeling awful, the worst you can ever imagine feeling, to feeling normal. And so that's what this is, kind of this roller coaster ride. And so I've had patients describe this in different ways, but overall it's always kind of the same, that they're just in this constant search to get to feel normal again. And for people in sort of chronic opioid use disorder, they're no longer feeling that sort of high or euphoria or pleasant feeling. They're just trying to feel they're normal so that they can do the things they need to do. So when we talk about addiction, there's a lot of focus, especially in the treatment community, on this like presence or absence of drugs, like is your drug screen positive or negative? In law enforcement, same thing. When people are on parole or probation, like what does the urine drug screen show? Are they using drugs or not using drugs? Addiction is not so much about the presence or absence of a substance, but it's about the behaviors that someone develops. And so I mentioned motivation. And so what happens is that when people are sort of have developed addiction, there are centers of their brain that focus on the motivation have told them that the most important thing right now is that you get more of this substance. And that's why we sometimes hear stories about people doing things that are completely uncharacteristic. People stealing grandma's wedding ring, breaking into a house, taking money, not showing up to important family events. It's because this motivation center of the brain is telling people that is the most important thing. And the frontal parts of the brain that are sort of higher decision making are no longer in control as people sort of go further and further into more moderate to severe addiction. So really when we look at whether or not people have addiction, it's not about are they using a drug or are they taking a medication, and this has become an important sort of part of the conversation because we used opioids for pain management as well, but really it's around the behaviors that people develop around that drug use. So things like loss of control, continued use in spite of negative consequences, cravings and compulsions. So I'm not going to go through this in detail, but again, it's just really, from a medical perspective, the way that we diagnose people as having the disease of addiction or the chronic condition of addiction. So I've already mentioned this, but I think one of the greatest challenges right now is that in this society we still view, by and large, addiction as this sort of moral failing, as people not having enough willpower to just be able to stop using drugs. Well, I've taken opioids for pain. I didn't have a problem with it. What's that person's deal? And really what we've come to understand, like I mentioned earlier, is that this is a chronic condition much like other chronic conditions where there's a strong genetic component. There are these environmental and behavioral pieces as well. And so really, from a medical perspective, I look at this much the same way that I look at like type 2 diabetes, which is adult onset diabetes, or hypertension. As we talk about treatment, we'll talk about medications that we use. And, with each of these, we know that people's behaviors play a role in the development of these conditions. We know that many people who have high blood pressure or type 2 diabetes, if they would just lose 50 pounds like I told them, exercise every single day, stop eating the foods that they know are bad for them, they wouldn't need medicine. What's their problem? And then much of our addiction treatment system says if you don't do what I tell you to do the way I tell you I want you to do it, then you're clearly not ready for treatment. If we did that in family medicine and said, well, if you're not doing what I told you with your diabetes care, then you just can't come back. You're not ready yet. You need to have more negative consequences so that you really are ready. It would be malpractice. It would be crazy, but that's the way a lot of addiction treatment works, and we'll talk more about that later. So really, from a research and understanding standpoint, we very much understand that this is a chronic condition. We understand that we need to move away from this idea that we should just tell people, oh, you should go to detox, for example. You should just go to treatment, and then when you come back, we expect you to be totally better. Because we understand that what happens in the brain is really complicated, and it's not just about are the drugs in your system right now today, and all we need to do is get them out of your system, and then you should be fine. And if you're not fine, then clearly that's your fault. What we really need to do is recognize that this is a chronic condition. We need to work on prevention. We need to work on identifying people early, providing treatment services, and then recognizing that for a lot of people, they're going to need recovery support services the same way we don't expect people with depression or high blood pressure or diabetes to, go to do all the stuff we tell them and then be miraculously cured. So I'll talk a little bit more about treatment later in the presentation. So I do always think it's important to talk about sort of why the hysteria, where we are in terms of numbers, what's happening in our country overall. So this is from the New York Times, and I think it visually is really powerful. So this is overall drug deaths, so not limited only to opioids, but the majority of drug deaths are opioid related. And so they're showing from 1980 until 2016 the number of drug deaths per year in the United States. This is over a 6-time increase in a 35-year period. And what they talked about in this article was that where we are in terms of total numbers of overdose death has far surpassed where we were when we were at the peak of car crash deaths in the 1970s, at the peak of the HIV epidemic in the 90s, and also at the peak of gun violence deaths in the 90s. And so these were sort of previous public health crises during our time. Drug overdose has far surpassed all of these. And unfortunately, as you can see from the trajectory, it does not look like it's getting better anytime soon. And so when we talk about the national story, what people have seen in the media, my guess is that many of you have heard about sort of doctors overprescribing. And we often hear this story about doctors overprescribed, someone had pain, doctors gave too many pills, the person became addicted to pills, they maybe went on to use heroin, and then they may die of a heroin overdose. And so that's a common story that we often hear in the media. I think the challenge and the reality is much more complicated, as are most things in life, I think. And this book on your right, Dreamland, the author, I think, does a pretty good job of describing some of the trends that played into this opioid crisis that we have in the United States. And so one of the things he talks about is pharmaceutical companies and a lot of unethical marketing practices on behalf of pharmaceutical companies, them making claims that these medications are really safe. If they aren't working, you just need to prescribe more. He also talks a lot about the medical sort of community recognizing that a lot of people had pain, and they sort of came out saying there was an Institute of Medicine report that said that there were patients who were hospitalized who were in a lot of pain, and we were undertreating pain, and we're supposed to be healers, and we're not adequately helping people, so we need to be much more aggressive in pain treatment. This idea that acute pain leads to chronic pain leads to disability, so we need to get out in front of it. So there were pressures in those two areas. The other two things, and I feel like that's been in the media quite a bit, the other two pieces that aren't talked about as often that have been equally important in terms of the opioid crisis are economic decline. So if you look at the areas of the country that have been really drastically impacted, you'll see that these are often areas of economic decline, areas where extraction jobs or other types of factory jobs were really the mainstay. I'm actually from central Illinois in a historically coal mining community, so a lot of this sort of hit home for me. But people, areas that have had significant economic downturn, areas that have had a loss of jobs have really been hit very hard by the opioid epidemic in many parts of the country. And then the other piece that he talks a lot about are changing heroin trafficking patterns. And so we have these cities in the country like Chicago, like New York, like Baltimore, that have had long-term heroin markets. But really what we've seen in more recent years is that there have been new trafficking patterns really focusing on suburban America, focusing on smaller and middle-sized cities. So availability of heroin has been changing, and then what's in the heroin has been changing as well. We'll talk more about that. I think one of the other things that was really interesting is that when you look at who's selling drugs or the changes in these traffic, it also is closely linked to economic opportunity, right? And so he talks a lot about this community in Mexico where a lot of the drug trafficking channels were coming from. And the reason that they were able to recruit these young kids to do this pretty dangerous, risky job in the United States was for economic opportunity. And so I think that's really central to a lot of this, but it's complicated. And so this, I thought, was a great article in Politico, but the author says, the myth that the epidemic is driven by patients becoming addicted to doctor-prescribed opioids or painkillers, and there's a bunch in the middle. Only a minority of people who are prescribed opioids for pain become addicted, and those who die from painkiller overdoses tend to obtain those medications from a source other than their physician. And I think this is an important concept because we spend a lot of time right now focusing on how to get doctors to prescribe less, making sure that we're like catching the patients who are misusing pills. But really what we know is that, again, only we think about 10, sometimes up to 15% of people who are on chronic opioids for pain develop addiction. Now, whether or not that's the best treatment, we need a lot more research in that space, but the majority of people who are taking these medications for pain are not developing those behaviors around addiction. And what we've seen repeatedly now is that the majority of people who are misusing opioids or say that they're taking them for reasons other than pain, or taking meds that are not prescribed to them, are getting them from a friend or family member for free. And so again, this idea of catching the bad doctors and catching the patients applies in some circumstances, but pretty rarely. One of the things that's been fascinating to me about the opioid crisis in the United States is that patterns look really different in different places. And so when I was working in public health, I would often hear, oh, well, you know, we saw this really cool intervention that was done in rural, name the place. Don't you think we should do that here? And my sense was always like, it looks really different in different places. And so to give you some perspective, we know that prescribing practices look really different in different parts of the country. Rural Appalachia, again, where they lost a lot of jobs and other things, was hit really hard, tons of opioid prescriptions going out. Illinois, as compared to other states, is actually one of the lowest prescribing states, and Cook County specifically is one of the lowest prescribing counties in the country. So in terms of opioid pills, overall we're doing pretty well. Doesn't mean we couldn't do better, but overall we're doing pretty well relative to the rest of the country. So you might then think, oh, well, our death rates must be really low, right? If we don't have a lot of pills, our death rates must be low. But what we actually see in terms of overall drug deaths and also opioid-related deaths, we fall about in the middle. So not the lowest, but not the highest. But then when you look at the patterns in terms of which states are seeing increases in opioid-related deaths, or in this case just drug overdose deaths, you'll see that Illinois is one of the states that's continuing to see increases. Does anybody notice anything interesting about this map? Yeah, so, I mean, it's like the whole eastern half of the country, right? Or not the whole, but many. And so does anybody have a sense of why that might be? Highways? So population density, so this is rate, so that's sort of taken into account. And so one of the things that's been really dramatically changing pretty quickly is actually what's in the drug supply. So I'm not talking about prescribed drugs, but I'm talking about the illicit drug supply. And so people may have heard the term fentanyl. So this is a synthetic opioid. So this is an opioid that's typically made in a lab. Fentanyl can be prescribed for pain, but when we're talking about deaths related to fentanyl, we're typically talking about illicitly produced fentanyl. And so what we've been seeing, you know, when the CDC talks about opioid-related deaths, they typically talk about the 3 waves of the opioid epidemic. So the first wave is the purple line, which is prescription-related pills. And there were lots of people dying of prescription-related pills. We saw this increase. The second wave is the blue line, which is heroin-related overdoses. So there was some sort of shifting in many parts of the country where people were primarily using pills to some shift toward heroin. And then in more recent years, we've seen this dramatic increase in fentanyl, which is the orange line in synthetics. And so really here what we're seeing is that because heroin is illegal, there are sort of constantly shifting patterns that are a bit hard to track and obviously very hard to regulate since it's unregulated market. And so what's happening in many parts of the country, really the eastern, part of the country, is that there's more and more fentanyl being cut into the heroin supply. And so we saw this first in the Northeast, and it's just been working its way west. And so then the question often comes up, well, I don't understand, you know, drug networks are pretty sophisticated. Why would people be putting a substance into a drug supply if it's going to kill their customer base, which is a very good question. And I think the best way I've heard this described is if you think about the prohibition around alcohol use in the United States. How many people do you think sold beer during the prohibition? How many people do you think sold really, really high potency moonshine during the prohibition? Right, so you have an underground market. You're smuggling things into the country. And so are you going to go for something that requires a large volume, or are you going to bring something in that is a small volume that will go much further? And so what's happening, so this is a picture from Kensington Police in Canada, but showing sort of what's a potentially fatal heroin volume to fentanyl volume to now these newer synthetics like carfentanil. You probably can't even see it. It's like a little single tiny like salt grain in the carfentanil. And so when you have an underground drug market, there's no regulation of it. And so it's a little bit like playing whack-a-mole when I talk to law enforcement, that you catch this dealer or you get this supply and then another thing pops up. And so a lot of that's happening both in terms of the mechanisms by which drugs are being brought into the country as well as sort of what's in the drug supply. And so that becomes really challenging, right? So when you think about people who may use alcohol, when you buy alcohol at the store, you know the proof, right? You know how much alcohol is in it. When you buy drugs on the street, you really have no way to know what's in it. And so people who might be used to, and a lot of the patients I work with have been using heroin for 20 or 30 years. And so they might know what was the normal amount that they could use, but now lots of things are changing. And I saw a patient on Thursday who said, I feel like I've lost half of the people that I know. And these are not and they've been using for 20 or 30 years, and we haven't. So a lot of what we're seeing right now in terms of these dramatic increases is that we have this really quickly changing drug market in terms of the potency of drugs. So I'm going to give a really quick synopsis of what we're seeing in Chicago, just to give people some sort of perspective as it relates to national numbers. So in Chicago in 2016, the rate of overdose deaths in Chicago were double that of the national rate. So we were at 26.7 per 100,000 people as compared to 13.3. One of the big differences in what we see in Chicago as compared to the rest of the country is that the majority of the deaths that we see here that are opioid-related are due to heroin and fentanyl. We see very few opioid-related deaths to prescription pain medications. And so we also saw this huge shift between 2015 and 2016, in that there were significantly more people dying of fentanyl, and so that's the light pink bar is 2015, the dark red bar is 2016. Huge shift in terms of what people were dying from. Heroin continued to be the thing that was most likely involved in opioid overdoses, but fentanyl is really closely sort of catching up, unfortunately. Another big difference of what we're seeing in Chicago is that we have a much older population who's dying. Now, I want to be careful here because it's not necessarily representative of everyone who uses opioids, but at least in terms of who's dying of opioid-related overdoses, the population in the city of Chicago is older, 45 to 64-year-olds primarily, which is really different than the national numbers, which are typically younger, 25 to 34-year-olds. We see both nationally and in Chicago that men are impacted at higher rates, but that's not to say that women aren't impacted. We absolutely know that women do develop opioid use disorder and die of overdose. And finally, in terms of race and ethnicity, nationally we see that non-Hispanic whites have the highest rates, and we think a lot of that is due to sort of rural white America that's been hit particularly hard by this crisis. But in the city of Chicago, what we've seen is that non-Hispanic African Americans have the highest rates of death as compared to white or Hispanic, Latino, or other ethnic and racial groups. And you can see here, this is a map of the city, and so we see that the majority of the deaths, both by rate and numbers, are happening on the west side of Chicago. And so for people who aren't familiar, 290 is sometimes referred to as the heroin highway. So there's a lot of drug trafficking that happens there. A lot of people coming in from both suburbs and other states to purchase and use drugs. And we looked at this data in different ways, both by where people live, but also where people were actually dying. And we found that these communities have particularly high rates in both cases. So both people coming in from the outside and dying in their community, but also people that live there and dying there. So why did I share all of this? I think, first is that we don't have really great news right now in terms of what we're seeing in terms of the epidemiology. We see that the numbers continue to increase in most parts of the country. We see significant, but that being said, we see significant variations in prescribing practice, in drug availability, and also overdose death trends in terms of demographics. In Chicago, we're seeing that primarily illicit substances are involved, being largely heroin and fentanyl, but we're seeing higher rates in 45 to 64-year-old African American men. And we have to use this information to make sure that we are crafting interventions that are determined by the data that we have in our own communities. So I'm going to speak about sort of different approaches to the opioid crisis. There are actually many more than this. And one of the things I wanted to say first and foremost is that this is sort of as a public health professional, this is sort of a tricky area to follow everything that's happening, but also what impact something has. So because it's such a crisis, because there are so many dying, it feels a little bit like we're throwing everything against the wall at the same time and kind of seeing what sticks. The problem is when you do that, it's what we have to do right now, but when you do that, it becomes hard to say, okay, well, we saw an increase or we saw a reduction. Was it because of A, B, C, D, E, D, like, you know, who knows? And so it becomes a little bit tricky to figure out exactly what impact which intervention is having. That being said, we know that there are several interventions that have been repeatedly shown to reduce death, and I'll focus on those in the rest of the presentation. So one such intervention that's been repeatedly shown to be effective in reducing mortality is just treatment. And so I mentioned earlier that there are certain medications that have been approved for treatment of opioid use disorder. And so really central to all addiction treatment in this country is behavioral intervention. So often it may be individual counseling, it may be groups. Also, sort of peer support is central to much addiction treatment in this country through things like 12-step, NA, AA, et cetera. But for opioid use disorder specifically, there are 3 medications that have been approved for the treatment of opioid use disorder. And those medications are methadone, buprenorphine, or sometimes called Suboxone, and injectable extended-release naltrexone or Vivitrol. Interestingly, as much stigma as we have against addiction and people with addiction, there's also a lot of stigma against the use of these medications for treatment. And so I don't know if people have heard of these medications or what your impressions are of these medications, but I'll talk a little bit more about the evidence base and why we use them. Methadone and buprenorphine specifically have been shown to reduce mortality, so to reduce the risk of death among people with opioid addiction. There's also a lot of focus, and there have been a lot of articles around sort of we need more detox, right? That focus of like we have to get the drugs out of the people because it's the drugs that we're fighting, and once the drugs are gone, then the people are going to be fine, sort of this mental model. And what we know is that detox itself actually, I would argue, is not treatment. Detox is doing sort of a medical intervention of taking someone who has opioids in their system, who has become physiologically dependent on them, and taking the opioids out. We haven't actually done anything during that short 3 to 7 days to help them build new coping mechanisms, to help them be prepared to deal with those really low dopamine levels that they're going to leave with. And what we know is that people who go through detox are actually at increased risk of overdose the day they leave. And so I was talking to a patient a couple weeks ago. He's in his 60s, and he was telling me before he started medication treatment this last time, he was like, yeah, so I used to just go to detox like every 2 or 3 months, well, every 3 months, because that's what his insurance allowed. I used to just go to detox every 3 months. And I said, I said, that's really interesting. Why would you decide to go? And he'd say, well, you know, sometimes I just wouldn't feel good, and I'd feel like maybe it was just time. And I said, well, when you went, did you think that maybe this was going to be the time, that like maybe you were going to get better this time after detox? And he just looked at me like, are you crazy? Like, why would that work? Like, just going to detox for 3 to 7 days, I'm still going back out to the street. I still have all the same pressures. I still have no income. I still have no housing. Like, of course I'm going to go back and use. That's like a dumb question, doc. I would just go in to like get checked out, you know, try it out for a few days, but I'm going right back into the same situation. Why would it get better? And so I think that we really have to shift a lot of our thinking about what is treatment, this idea that we're going to send someone away for 3 days, 7 days, 28 days, and they're going to come back and all of a sudden everything's going to be better. Addiction is a chronic condition. It is not going to work, and we've seen that repeatedly. And so really we have to be thinking about longer-term solutions and really addressing multiple areas of people's lives, helping to support them to address multiple areas of their lives. The challenge in the treatment space is that right now only about 1/3 of addiction treatment providers actually offer medication. And so I'll show you in the next few slides sort of how the medication works and why we think that it's important that people have access to it. Doesn't mean everyone has to be forced. I would not recommend that for anything, the same way we don't force other patients to take medication for other chronic conditions, but it should be offered and it should be available. So to be clear, methadone and buprenorphine are types of opioids. They work a little bit differently. They have a very long half-life, but one of the reasons there's so much stigma against them is people often say, why would you just trade one drug for another? Just trading one addiction for another addiction. And if you remember that slide from earlier, that people with chronic opioid use or chronic opioid use disorder are sort of revolving between feeling really, really sick, really, really awful in that sort of survival mechanism of I have to get opioids in my system just to feel normal. And so what we're doing when we use medications like methadone or buprenorphine is that we're trying to take people from that sort of survival up and down roller coaster into a place where they just feel normal, where they just feel like they can actually engage in therapy. where they feel like they can engage with their family, where their brain isn't constantly telling them, I know, like, just to feel normal, just to feel better, just to be able to focus, I know what you need to do. You need to go and get opioids. And so really the goal with these medications is that we get people into this steady, stable state. We can talk about stigma during the question and answer section, but there's just so much stigma that many people are afraid to even say they need treatment, and definitely afraid to get this treatment. And a lot of sort of, you know, in a AA type of group settings, people tell you that you're actually not in recovery if you're on these treatments. One quick story. So I had a patient, and he was an older gentleman in his at least 60s, I don't remember exactly, and he had been in treatment with us for about 6 months, and he came in and said, you know, I have to get off this medicine. My mom says I can't be on it. And my first thought as a parent was like, I need to meet your mom. You're in your 60s and you're still doing what she tells you? My like 5-year-old won't do what I tell her. And I said, okay, well, like, tell me more about your thought process here. Do you feel like you're ready to stop this medication? He was like, no, not really. Like, this is the best I've ever done. This is the longest I've been sober, sort of outside of being incarcerated. This is the best that I've had it. And I said, okay. And so we talk about it. And he's like, but, you know, I got to do what my mom says. So we call his mom. She was elderly and not able to come in. That was my first request. Can she come in? And so we call her. And I said, so tell me what's going on. And she said, well, my son doesn't need this medicine. He's better. And I said, okay. I said, well, tell me what was going on before he started treatment. And she said, well, it was awful. Like, he was never around. He would sometimes, he was caring for her. He was basically her caregiver. He would sometimes take our grocery money and he wouldn't bring groceries back. Sometimes he'd be here and he'd be passed out asleep. Other times he'd be gone for days at a time. He wouldn't show up to take me to my appointments like he was supposed to. I was like, okay, so what's going on now? And she's like, well, now all of that's perfect. Everything's better. He's doing everything that I need him to do. He's taking me to my appointments. I said, okay. I said, did you ever think that maybe the medicine's part of why he's able to focus and get all those things done? And she said, well, no, but I don't think he needs it. I feel like he's addicted to this medicine now. Now he's always coming in to see you guys and he's doing all this stuff. And I said, okay. And I was like, well, do you know anybody that has high blood pressure or diabetes? To my earlier statement. Well, of course, you know. And I said, well, do you think it would be appropriate if we told those friends of yours that they could only have medicine for 6 months? And that if they don't do all the things that we want them to do, then they can't have it anymore, even though we know it reduces risk of death, even though we know it does has all these other positive impacts on their life. Well, of course not. And so this is really a similar thing. And so there's this sort of all of this stigma against use of medication for addiction treatment. But what we know is that specifically with methadone and buprenorphine is that we see greater retention in treatment. We see reduced illicit opioid use. We see reduced risk of overdose death. We see reduced HIV transmission, hepatitis B and C transmission, increased length of life, and specifically in the methadone research, we've seen that people have increased rates of employment and decreased crime and recidivism. So this is a really important piece, not the only piece, but an important piece of how we need to move forward in addressing the opioid crisis. This is just showing some data from Baltimore City that looked at the reduction in overdose deaths as they increased access to methadone and buprenorphine. They saw about a 50% reduction in overdose deaths between 1995 and 2009. And this is a little bit outdated now, but this is actually looking at the treatment gap in this country. And so the top line, the solid line, is looking at how many people we think need access to opioid addiction treatment. And then the line right below it is if you add up all of the access to methadone and buprenorphine, and we know this was an overestimate, but that's where we thought we were in terms of access. So if you look at that gap in between the two lines, that's sort of where we need to be moving, is increasing the access to evidence-based and effective treatment. So the next couple of things I'm going to talk about are really, you know, one of the other important ideas is that this sort of assumption that everyone wants treatment. And everyone's ready for treatment. And what we know from asking people who use drugs, do you want treatment? A lot of people say they're not ready for treatment. They don't want treatment right now. Now, partly I think personally that that's because the way that we've offered treatment is often stigmatizing and somewhat punitive and isn't fully supportive of people and where they are. But often it's just that people truly aren't ready. And so we have to do everything we can to also support people who might not be ready to engage in treatment to make sure that they're able to live long enough to get to treatment. Also, we recognize that there may be people who use drugs who don't even have opioid use disorder, who might not need treatment, but because they're using this illegal drug supply, it's really hard for them to know how to use drugs more safely. And so there are some other things that have been shown to be effective in terms of trying to reduce risk for people who are using drugs. And so one of those things is something called naloxone. Have people heard of naloxone or Narcan? So naloxone is a medicine, sort of like an EpiPen. Are people familiar with EpiPens? So when someone's having a severe allergic reaction, a friend or family member could pull out this, epinephrine, this medication that could help them to stay alive during a severe allergic reaction. Naloxone works in the same way, but rather than using it for a severe allergic reaction, we use it during an opioid overdose. The only thing it does is go to those centers in the brain where the opioids are attached and knock them off. So when someone dies of an opioid overdose, essentially the respiratory centers shut down and you stop breathing. And so this medication, it goes and it basically reverses that process. So if someone has stopped breathing and they get naloxone in time, it allows them to start breathing again. And so there is sort of a lot of focus right now on increasing access to naloxone, so making sure that definitely people who use drugs, as well as all emergency professionals, and ideally friends and family have access to this medication so that if they encounter someone who's experiencing an overdose, they can give this medication. There's often, when I talk about this, the first immediate response is, well, you can't give this to people who use drugs because they're just going to use more drugs, or people are going to have riskier behaviors. And what we've seen in the research is that actually hasn't happened. Giving naloxone to people who use drugs hasn't increased their drug use, but in fact it's been shown to increase the likelihood that someone might enter treatment. We think largely because just the engagement of saying, like, I know you're using drugs and I think you deserve to live. I want you to have the tools you need to be safe, are really effective ways to engage people in other services. It's been shown to be cost effective, it's been shown to reduce overdose deaths, and it's also been shown that the people most likely to save someone's life are other people who use drugs, right? Because they are likely to be in other groups of people who are using drugs, and so in terms of sort of focusing these efforts, we really need to make sure that people who are most at risk are also the people who have the right tools. An important thing in Illinois is that we've passed some great laws to be able to increase access. So one is it allows providers, medical professionals, to prescribe medicines to people who may be intending to use it on someone else. So for example, if you come in and see me today and say, my sister has high blood pressure, can you give me a medicine in my name that I'm going to give to her? And I'd be like, no, I can't do that. It's illegal, actually. But if someone comes in to me and says, my sister is using heroin and I'm really afraid she might die, can you prescribe me naloxone? I can say yes. So you typically can't do that in most medical cases, but for this you can. Illinois also allows pharmacists to be able to dispense naloxone. So if you're going into a retail pharmacy, you can ask the pharmacist there, can I get naloxone? I just want to have it. They can give it to you without a prescription. There are also some different community-based programs that will give naloxone for free, and I have information on those if people are interested. And it also provides some criminal and civil immunity. So sometimes people say, oh, well, I'm really nervous. What if I give it and it doesn't work? Or what if I do it wrong? And so there's some protections legally in terms of, as long as you're acting in goodwill and, doing what you thought was the right thing, it provides some protections there. There are 3 formulations. One is an auto-injector, so literally you just pull the cap off and it tells you exactly what to do. You push a button. One is a nasal spray. You just spray it up the nose. And the third is one you pull up in a vial with a syringe. So that's sort of naloxone in a nutshell. I actually have all 3 formulations. If people want to see it, I'll have them at the coffee hour if people are just interested to look at what they look like. But I always carry it with me. And one other side note is I once gave a talk on this to health professionals, and I got an email the night after. And a woman said, I was at your talk. I remembered thinking, I'm going to go to a pharmacy. I'll get that. It seems like a good idea. And on the way home, on the L, I saw someone having what seemed to be an opioid overdose, and I didn't have it. And I just want to say thank you because now I know what I need to do. So I think it's something that, the chances are probably low that we would necessarily see someone on the L, but it is possible. And definitely of the patients I worked with, so many of them have saved people's lives with this medication. The last thing I'm going to talk about is supervised injection facility, and I'll be brief. But I don't know if people have heard about this in the news, but there are a lot of jurisdictions, primarily cities, but a few states, that have been talking about this idea of giving people a safe place to use drugs. Not a place to buy drugs, but a place to come and use drugs in a more supervised sort of way. And the idea is that, they'll have sort of clean environment, they'll have clean equipment for using drugs, and that they don't have to be in fear of being arrested while they're there. And the goals are that it's safer environment, that it improves the health status, a lot of focus around reducing HIV and hepatitis C, but also in many countries where people that were sort of using drugs in public settings, that it would bring people sort of off the streets into a more contained environment. This is a picture. So There's this one site in Canada called Insight that has done a ton of research on their outcomes and found a lot of really positive outcomes. But this is what it looks like. People sort of come in, they get their equipment, whatever equipment they're going to use drugs, and then they go to this sterile surface to be able to use drugs. And then when they're done, they go into sort of a recovery area or like more of a living room area. And then if there happens to be an overdose, there are people there that can respond effectively. There are, these numbers are a little bit outdated now, but there are over 97 facilities in over 66 cities across the world in 11 countries, and there are none that are sort of official in the United States. There are tons of research findings from this one site in Vancouver, British Columbia. They've seen reduction in overdose deaths, reductions in syringe sharing, increased use of addiction treatment, reductions in public disorder. They have not seen negative changes in community drug use patterns, and no increases in initiation into injection drug use. So again, people are always worried, like, well, if we make a place, then more people are going to use drugs, or people will use drugs less safely because now there's a place, and we haven't seen that in the literature. So takeaways here that we're doing a lot of things sort of across the public health sphere to try and address the crisis. We have seen some promise, particularly around treatment, naloxone distribution. In the United States, there are no sanctioned facilities. There was a research article actually on an unsanctioned site at an undisclosed location, so we know there's at least one operating sort of underground in the U.S., but there are a lot of other areas under investigation. And this is one of my absolute favorite articles about the opioid crisis, because I think, you know, people are often looking for a silver bullet. Like, what is the thing? What is the thing that we're going to do? And I think the bottom line is that there's not going to be one thing. Much of what we're seeing, in my view, is sort of a broader conversation of where we are as a society about the way that we view drugs, the way that we view people who use drugs, but also the compounding factors that access to housing, access to mental health care, access to income and jobs that pay a living wage is really compounding where we are with the opioid crisis. And so two of the quotes from this article are that poverty and substance use problems operate synergistically. At the extreme are reinforced by psychiatric disorders and unstable housing. And their second statement was that an exclusive focus on opioid supply hampers effective responses. So if all we're doing is trying to catch the drugs and limit the drugs, we're going to miss a lot of other pieces of this epidemic that are so critical. And so the last things I wanted to close with, so there's a Chicago Recovery Alliance is a sort of, they provide a ton of different services for people who use drugs. And Suzanne Karlberg-Rassich did a project recently where she worked with people, participants who received services there, to take pictures and answer a variety of questions and bring them back. And so she actually had a really cool photo display on this past Friday, and she gave me permission to use these photos. So thanks to her and the participants in the program. And I think one piece that's really an important piece of this epidemic is the level of stigma and also the effective criminalization of drug use. And so we've really come to criminalize what we now understand to be a medical condition and the impact that that has. And so these are statements and photos from the participants. And the first one says, "I feel trapped and isolated completely. Even windows have walls in front of them." And so I think with a lot of people that I work with, you know, they have compounded years of trauma, of negative experiences. Much of their lives have become around sort of that roller coaster ride of getting drugs, feeling normal, coming down. Much of their social network is sort of engaging in the same. And so the way out becomes really, really challenging, because a lot of people have criminal charges strictly for drug use. Their ability to get work and to get housing is really impacted by that. And so it becomes really challenging to figure out what is your way out. If I can't get a job, and because of my criminal record I can't get housing, what am I really going to do? And so I think that is a really powerful both image and statement. And the second one is that the second statement was that it starts to feel like I'm a prisoner, but literally and figuratively. I feel like there are so many factors that contribute to my story, but to open up means to incriminate myself, so being a user is a lonely life. A couple other things going on in Illinois that are important to be aware of. So Illinois has that Good Samaritan law that I mentioned earlier, but one of the challenges is that we also have a loophole in the law that allows for what's called drug-induced homicide. So the idea initially was that this allows prosecutors to go after drug dealers. But what's happened in some cases is that there could be two friends. In this case, there were two young friends who were using drugs together. And so a typical example might be that today I buy the drugs and tomorrow you buy the drugs and we use the drugs together. And in this case, there were these two young individuals who, one of them brought the drugs, they used the drugs together. One of them died, the other didn't. The person who didn't die was the person who had bought the drugs that day. And he was charged with drug-induced homicide because he gave drugs to his friend. And so he was prosecuted in prison because he and his friend were using drugs together. And he was prosecuted for homicide, for killing his friend. And the mother of the boy who died actually said, I don't think that he should be in prison. But that was still what happened. And so this is of concern definitely in Illinois. It's happening in other areas as well. And so with that, I will close. But this was one of the other pictures from the project that I mentioned that Suzanne led. And this individual said that he constantly feels like a target. Like he has a target on his back. And so the sign, in case you can't see it, says, I'm not a criminal. I need help. I have a family, a job, and hope. And I'm more than just a junkie. And so given that I was coming to the Ethical Humanism Society today, I wanted to put some faces to sort of the opioid crisis and really hope to answer some questions or hear some dialogue about the way that we view drugs and drug use in this country, but also the way that we view people who use drugs and how that may actually be perpetuating some of the situations that we're in right now. So with that.
Thank you. I have two questions. Is meth a good thing or a bad thing? Because I've heard, like, Southern Indiana, they have more meth labs there, but then meth is something that helps? And where does mental health come into all this? Those are my two.
So thank you for the question. So meth labs that you're talking about are primarily referring to methamphetamine. So not methadone. So methamphetamine is a stimulant, which is super scary as an addiction specialist in that we don't have great outcomes with any forms of treatment. And unlike opioid use disorder, we don't have medications that are approved for treatment of methamphetamine use disorder. And so I'm from, like I mentioned earlier, rural Illinois. And so where I'm from, methamphetamine has typically been a much larger problem than opioid use disorder. And so when we hear about meth labs, we're actually talking about methamphetamine, which is a stimulant, as opposed to methadone, which is a treatment for opioid use disorder. It's also kind of complicated because methadone can also be used for pain treatment. And so sometimes patients who have cancer or other pretty severe, usually pain conditions, may receive methadone for treatment for pain. So methadone is an opioid, long-acting, that can be used for pain or addiction treatment of opioids, and methamphetamine is typically, stimulant and very separate. Yeah.
Are some states better at treating opioid addiction than others? Yes.
So I think, definitely different states have different resources. I think one of the other challenges right now is that a lot of people, I showed the numbers, so, we're looking at primarily men in most states that are impacted and needing treatment. Not to say women don't need treatment, but if people don't have insurance, access to treatment is a real challenge. So especially states that have an expanded access to Medicaid, the insurance for people of low income, treatment access often becomes even harder in those cases. And so I think there are a few challenges around addiction treatment. One is just, is there any treatment? Next is, who's paying for it and how do you get it? And then the next is, are people offering the medications that actually have the best outcomes? Not to say people have to get it, but that, we want people to have access. One of the other things that I think has been really interesting in the treatment space is that we know that people who are leaving incarceration, whether it be just a few days in jail or people who are in prison, have really, really high rates of death, about 13 times their counterparts who have not been incarcerated. And so some of I think the really important work that we're seeing largely in Rhode Island, but also in New York City, is that we're actually starting people on these medications for treatment while they're incarcerated. And so I know Rhode Island's tiny on that map, but Rhode Island is actually one of the few states that's been in the heart of the fentanyl crisis that has seen a reduction in death. And so they've been really aggressive about expanding access to treatment, but also expanding access to treatment in criminal justice, which has been really important. And it's sort of a broader conversation as well.
It was a wonderful talk, presentation. I was curious to know if that example in Vancouver, and you said it's like in 90 countries, is that expensive?
Yeah, so it's in primarily Western Europe, Australia. Sorry, I'm going back just to see the numbers. And these are, again, a couple years old because Canada has actually opened multiple more facilities in the last year or two. 11 countries. And so it depends on the model, and there are really different models. The model that they used in Insight is a more medical model where there are medical professionals like nurses there. There are models in other countries like Germany, for example. I've met people that run some facilities there that are more sort of peer-led models, or students maybe working in the facilities. And so I think it can look a lot of different ways, and it's actually something that from a public health standpoint, I would love to see more research and looking at sort of what are the different outcomes, and do you really need nurses there? A lot of people would say no. You don't. You know, you'll call 911, you'll resuscitate the person and call 911. And so I think it can look a bit different in different places, and expensive is sort of relative, right, in terms of how you would view it. I think one of the other challenges, if you think about the costs associated with resuscitating an overdose right now as they stand, you know, so typically if someone overdoses, you call 911, they have an ambulance ride, they then may get admitted to the hospital. Like, those are really, really expensive services. And if we know, some cost analyses have been done out of San Francisco looking at the potential cost savings. If we can reduce HIV and hepatitis C transmission, treatment of those conditions is really expensive. And so by and large, models have shown that they're highly cost effective when you take into account all of these different things that, you know, if you can prevent skin infections, people who have skin infections can be hospitalized for weeks and sometimes months, depending on the severity of the infection, if it goes into the bone, et cetera, et cetera. If you can prevent that through these types of facilities, you can have a lot of cost savings.
I've read that due to fear of legal consequences, a lot of physicians are limiting the amount of opioids they prescribe for patients to often below what the patients really need, and that this is, in turn, is driving a lot of those patients to either street opioids or heroin. Do you have any thoughts on that?
Yeah, so that's a great question, and it's come up a lot. We've definitely seen particular states. I'm always reminded of a talk I heard by the Kentucky drug czar at one point. This was a while ago, maybe like 5 or 10 years ago, and he said, well, we had a big pill problem, and we fixed it, and now we have a big heroin problem. And so I think that it's not to say that in every case where we reduce pills, people automatically move to heroin. But I think one of the challenges, and that's why I brought up that sort of slide that talked about how the majority of people who get opioids for chronic pain don't develop addiction. But what's happening is that there's this immense pressure on physicians and nurse practitioners and physician's assistants, like, you have to prescribe less and you have to do it quickly. And so a lot of people are really scared. And in some states, they took licenses away. They're continuing to take licenses away. They're putting a lot of regulations and rules, and people are really nervous. And to be honest, working with patients with complex pain is not easy. We don't have great solutions for chronic pain, like just in terms of different modalities. And some of the things that may work, like massage and acupuncture and pain psychotherapy, people don't have access to. They're not covered by insurance, or there's no one to provide the service. And so you sort of feel stuck between a rock and a hard place, and I know, poor physicians, right? But I think, you know, so people are getting nervous, and they don't have the tools they need to help patients with pain. And so, you know, it's the easiest thing sometimes is just to say, I'm not going to see you anymore. This feels too risky. Your dose is too high. You need to go somewhere else. And so then the question is where? Where are people supposed to go? And right now we don't have a lot of places for people to go with really complex pain. So yeah, I think in some circumstances it may be leading to sort of an increase in heroin use. I think, again, the bigger thing is that it's a lot of supply and demand. So if there was previously a ton of pills available from one mechanism or another, from, you know, someone's medicine cabinet that was overprescribed or whatever the circumstance may be, as we're shrinking that supply, if supply of heroin is simultaneously increasing, like, there is going to be some shift. And so there's a lot of supply and demand and sort of, you know, drug trafficking, et cetera. And so I think we have to be really careful as we're passing legislation around limiting access or making providers feel more scared to work with patients with pain, because we may be sort of abandoning patients and putting them in really risky situations.
Hi, this is more about addiction as opposed to just opioids. Excuse me. I understand that the medical profession has, in large part, accepted addiction as fitting the disease model. What impact will that have on addiction in general, and what could the medical field do to help the general public understand that as opposed to being a moral failure?
Oh, it's a great question. I would love to hear others' thoughts on it. I mean, I think from a scientific standpoint, we've started to understand this. I think that providers are humans. Medical providers are humans, right? And if we've come up for however many years hearing that this is a moral failing, so even if we tell people the science, it doesn't mean that they're automatically bought in. So I think that's first and foremost. That being said, I never learned anything about addiction as a med student, and I didn't go to med school that long ago. And so we have a long way to go in terms of education. I think one of the things that's really helpful, to the extent people feel comfortable, is there's a statistic that 1 in 3 people have known someone, been impacted by some way by just opioid crisis. So addiction, I'm sure the number is even much higher. I think it's really helpful for people to hear that someone they know has struggled with addiction, because it humanizes it, right? And so it's really easy to say, not me, not my community, not this, not that. I think that helps a lot, whether it be a colleague, whether it be a patient, whatever it is, to hear people's stories can be really helpful. I think it's not something that's just on the medical profession. I think it's really on all of us and all of our, whatever we do in life, whoever our social networks are, start thinking about this differently. If you think about how we used to, as a society, work with people who have mental illness, we would often institutionalize them. And that was not only appropriate, but that was viewed as the right thing to do. We've since come to understand that is not the right thing to do. I would argue that at least everything we know about science and medicine, that incarcerating people who use drugs is not the right way to treat people. It's institutionalizing them in a different way, and we're not helping them build the tools to come out and lead the lives that they want to lead. And so I think it's a much broader conversation. Medicine will not fix that problem by itself. It's going to take a much larger sort of force from a larger section of the population to be able to address that.
I'm just wondering, I'm hearing all this clinical stuff about addictions, but I think the conversation really needs to be about a blend of head and heart, about looking at when people are having these issues with addictions, that there are no legs left on their table. There is no spiritual life. There is no family connection, I believe. There's probably a lack of purpose. And like I say to my kids a lot, we're creators. We're not consumers. And so just changing the whole idea that having a discussion about what makes a purposeful life, because there is no way out of this without looking at family patterns, access to things like education, a community social group. Can you talk about that a little bit? Do you know what I mean?
Yeah, absolutely. And so I think, I tried to get at that a little bit. I'm definitely guilty of medicalizing this as a physician, and that's what primarily my job is. But I think, to your point, there have been some people who have described the opioid crisis and also increasing rates of suicide as diseases of despair or deaths of despair. And I think, to your point, people need access to education. People need to feel hope. People need to have a sense of community. Now, whether that community is their actual biological family or other type of community, their chosen family. But absolutely, for someone to, quote unquote, get better or be in recovery, typically what I see is that people need to have a sense of belonging and a sense of purpose. And that can look a lot of different ways. And I think, when we work with our patients, the thing, I don't care what your thing is. It doesn't matter to me if you have a job or if you're volunteering or if your social network is your family that you were born with or your family that you've made. But people don't tend to recover if they don't have the things that you've described in some way, shape, or form. And so we don't, where I work, mandate that people go to meetings. We don't tell people what their recovery needs to look like, but we try to work with people and support them to make healthier, more positive decisions for themselves. And that can look a lot of different ways for a lot of different people. But absolutely, I mean, I completely agree with you. I think I come at this a lot of times from a policy, legislation, what are the things we do to influence these other things, so that may be what you've heard some, but we absolutely need a stronger sense of community and support for people.
I was also thinking about it in terms of psychological tools for people to have, when everything looks black and you just don't have anything left. I have in the past been suicidal, so I understand while I haven't had an addiction problem, I have a father who was an alcoholic, what that can look like, what that can feel like. And I'm like a educator, and I think getting at the root cause of not feeling like you have options and you don't feel creative, you don't feel connected, that nothing is going to solve it without looking at those things.
And I absolutely agree. I think one of the points that I was trying to make in this is that sort of on top of all of what you just described in terms of people not feeling hope, we are also criminalizing this, which only makes it harder for people to come forward. And so when you talk about not having hope, the fact that we've criminalized drug use actually, I think, perpetuates a lot of the lack of hope that people experience, whether it be because they have criminal charges around drug use in the past or otherwise. But I mean, I completely agree. I think people need a lot of psychosocial supports. And so there are, if your question is specifically about psychological tools, we have different types of therapy, like dialectical behavioral therapy, cognitive I mean, I could go into all of that, but I'm guessing that's not what the broader audience is interested in hearing about. But yeah, we absolutely understand. I think one of the challenges I have when we look at the way sometimes treatment is provided in the U.S. is that there's a lot of shaming and guilting people. I actually gave a talk last week where someone said, I'm an alcoholic in recovery, and I don't agree with you at all. I think people have to go through detox. They have to feel the pain. They have to be ashamed. And I very respectfully, I mean, I understand everyone has their own story. I don't personally see that shaming people and guilting them and making them feel worse about themselves is very helpful, clinically speaking. And so I think that, to your point, yeah, there are a lot of different ways that we can support people. I don't think that supporting people is enabling them. I think we have to kind of meet people where they are and see what they need and see how we can support it. And it looks different for different individuals.
Thank you for your very informative answer. This question relates to the last one. You've explained that this is a multifaceted problem with legal, social, psychological, medical components. And I'm just curious, you now are an expert in this area, and is there medical training now that is available through medical schools?
Yeah. So I think, the way that most educators treat to what we're going to be tested on, right? And so in medical school, we know that we have these exams coming that we have to pass. And so I think one of the smartest ways to get people to train more in this space is to start adding addiction-related questions to those tests, because then people have to train to it to be able to answer the questions. So that's first. We're not quite there yet, but definitely we're seeing more and more curriculum in this space because it has become such an issue. Similarly, I was really surprised. I have some social work colleagues who work at some of the larger social work schools in the city of Chicago. Still in social work school, addiction is like an elective. And so we think about, workforce is a huge challenge right now, as we need so many more trained professionals. We actually don't have enough of them. And so a lot of times people say, oh, we'll just hire a social worker to do that. And I'm like, does a social worker, did they have any training in addiction? Because most will not. And so I think increasingly, newer generations of providers, we're going to see increased levels of education, but we have to apply some pressures to make sure that in nursing school, in medical school, in NP and PA school, and social work, and all of these fields, people have some basic knowledge. And so then, yes, there are now 2 different paths that people can become certified addiction specialists, but there are not nearly enough of us. And so part of this movement to say this is a chronic condition, everybody knows how to work with people. Everybody needs to know how to work with people with addiction. We can't say only these X number of addiction specialists should do it. It should be all health professionals getting more education. And so yes, we'll need specialists, but we need people to be more comfortable across the board. Yeah.
Hi, so that facility is a really interesting idea to me. And so do they like provide you with like clean needles at the door and that kind of thing?
Yeah, and I'm sorry, I didn't, for the sake of time, didn't explain it. So yeah, they'll have all of the clean equipment for both syringes as well as like any equipment needed to cook up drugs. I think one of the other things is that many people in Chicago, but in other parts of the country, don't always inject drugs. They may be snorting drugs. So really having all the equipment that people may need there and available, and that you have to use that sterile equipment, and then you dispose of it before you go to not put others at risk by like leaving a syringe in a park or something like that. You don't buy drugs there. You can only bring drugs in, but all the equipment you would need to use drugs would be there.
Last question. I know Dr. Salisbury-Afshar will stay and ask more about last question.
I read this week that Illinois just got a $43 million grant from the federal government to deal with opioids. Did you see that this week?
We've all been following the money coming
Great.
into Illinois pretty carefully, yeah.
So it sounds like a lot of money to me, but I'm curious whether Illinois got a lot more than other states got. I'm wondering if in D.C., our state is seen as in a crisis situation right now, and that's why they injected the money into the state, or, you know, how significant it is that that money came here, and what would be the appropriate disbursement for it?
Yeah, so there have been several boluses of federal money directly to states. And so the federal approach right now has really been to sort of give the money to states. States decide how they're going to use it with particular parameters in place. So this most recent stream of money was pretty clear that if you're going to fund a treatment, you need to fund treatment that uses medication because they have the strongest outcomes. Not that you can't fund with other dollars, other types of treatment. I can't tell you like where Illinois ranks in comparison, but they use sometimes complicated algorithms to decide who gets how much money based on what is your increase and what is your total number of population. But I have the links and I can send them to you if you want to see sort of where we are in terms of other states. But yeah, I think by and large they are trying to really push states to implement evidence-based practice. They're trying to encourage that people are using research to inform what we're doing, but also, you know, giving flexibility often to try new things. And so this is the second round. The first was state targeted response. This is SOR, state opioid response. But there have been a few rounds of funding, and definitely I would say the largest infusions of funding in Illinois specifically are coming from the federal straight to the state. There's also some new CDC money going to the state health department to improve things like surveillance. So yes, definitely there's a lot of money flowing from the federal government directly to the Illinois state government. And yeah.